Right. I'd like to introduce our first speaker. It's Daisy Taylor. Daisy is one of our senior paediatric trainees in the region with a particular interest in infectious diseases, which she's still thinking about at the moment, and has recently returned from 12 months out of programme experience working with one of my old institutions, the MRC unit in the Gambia, and is going to be telling us about her experience, what she learned, the challenges, and what she's brought back with her, and how an unexpected pandemic impacted that work over the last few months in particular. So without further ado, I'll turn myself off and let Daisy pick up the thread. Welcome, Daisy.
Great, thanks, Steve. Right, I'm just going to share my screen. Perfect. Hopefully you can all see that. So yeah, my name's Daisy. I'm one of the ST5 trainees in the region, and I'm currently working at James Cook Hospital. So I'm going to talk a bit about my experience of working as a volunteer doctor for the Medical Research Council in Gambia, West Africa. Steve asked me to kind of talk through why I applied for OOPE, kind of adapting to the work initially, challenges overcome, and then a bit about how the pandemic affected me and the service that was provided by MRC. It's quite a bit for 25 minutes, so we'll see how we get on. But in terms of kind of why I applied and a little bit about my background, I've always been interested in global health and tropical medicine right since medical school. I did my elective in Malawi in a paediatric orthopedic hospital, which was really interesting. I intercalated in international health and went back to Malawi at that point to do my research project. And then I did F1, F2, and then I thought, I think I need another year off. So I took a year off and went to Liverpool, did the diploma of tropical medicine and hygiene. And then I ended up in Cambodia, and I was working out there for a few months with a charity called Transform Healthcare Cambodia. And it's a health partnership. So it's kind of linked with THET, and it's a link with some of the hospitals in Battambang in Cambodia, with some of the hospitals in the north of England. And I worked on the board of directors for 6 years, and it gave me a great kind of insight into cross-cultural settings and teaching and kind of also managing a charity, things like that. During that time, I continued with my paediatric training, got my MRC PCH, and I had 2 little boys. And then by the end of that time, they were both coming up to school age. So it seemed like a natural time for us as a family to kind of think about what new and exciting things we could do. So that's kind of why I applied for the year working abroad. And this is MRC in the Gambia. So I did take the whole family with me. My husband's a doctor as well. He's a gastro registrar in the region. So essentially it's a huge research facility, and there's lots of local staff, as well as students visiting researchers. There's always people in and out. And for the year, I worked in the clinical services department, which aims to provide healthcare for all the staff members there, all the research participants, but to the local community as well. There's 3 wards, 2 isolation rooms, 42 beds in total initially, although that was scaled up massively for COVID. There's a nurse-led clinic, and then there's a doctor-led OPD as well. There's X-ray, clinical labs. In terms of staffing, there was 4 consultants, 2 of whom were part-time. There's 1 staff doctor who kind of acts as a GP for the unit, and about 7 junior doctors at any given time, but fluctuates depending on volunteers. About 40 nurses in total, but that's a mix of qualified and auxiliaries. So in terms of adjusting to work in the Gambia, I thought the best way to explain it would to be just to talk through like a typical day in the life of kind of thing. So this is all pre-COVID. So your day would often start with a morning meeting with all the doctors and nurses, talk through new patients, any problematic patients, that kind of thing. 9:30, head over to clinic. And then the sooner you get through the patients, the quicker you finish in clinic. So maybe you might get some time for admin in the afternoon. And then there might be a teaching meeting or some kind of update meeting in the afternoon. And then if you're on call, obviously you go to the ward, take a handover, and then you might get called out once or twice in the night for a new admission or someone who's poorly, that kind of a thing. So Clinics were busy. You'd often see 25, 30 patients in a day. And at the time, I kept a list of every single patient I'd seen, more so I could chase jobs because I've got a memory like a sieve. But I'm actually really glad I did it because it's fascinating looking back and seeing the range and the breadth of kind of conditions that I saw, and also to remember some of the patients, because some of them I think I will, remember forever. So here's a typical day of mine. And you can see for the first patient, it just says admit. And I remember why. It's because he was wheeled into the clinic room, practically moribund, with sequelae of cerebral malaria, which I'd never seen before. So I took one look at him and admitted him straight to the ward. But actually, that was a chap that did really, really well. It was phenomenal. You can see all the patients marked with a little cartoon heart. That's all my cardiac patients. And within the year, I saw everything from, end-stage rheumatic heart disease. I saw teenagers with tetralogy of Fallot because they'd never had it repaired. I saw, I think, 3 transpositions in a year, which was really interesting. And then plenty of other stuff that I'd never really looked after before, double outlet right ventricle. And then there was a significant proportion of kids that had really complex anatomy that we just couldn't get to the bottom of. I also saw malnutrition and sickle cell disease kind of on a daily basis. And things like that were essentially new diseases for me to learn how to care for. So that was really interesting. Reassuringly, there were still plenty of, bronchiolitis and viral induced wheeze, all those nice normal bread and butter things that I felt really comfortable with. So after clinic in the afternoons, you might be able to squeeze in some admin time. And often for me, that was spent referring patients to charities which could provide care overseas. So Chain of Hope took children for cardiac surgery because there's no services available in the Gambia. And even thinking of some of the countries on our borders like Senegal, they were very limited in what surgery they could offer. And they were in the very early stages of building a service. So for the children who are actually really sick and really vulnerable, that wasn't necessarily a great referral pathway anyway. But we had, I think by the time I left, there was over 350 kids on the waiting list for assessment. So the burden of cardiac disease was absolutely phenomenal. Mercy Ships was doctor near us during the time that I was out there, but they're massively busy and oversubscribed. It's great work that they do, but getting a child to be referred was actually really difficult. And then Willing and Able, they provided surgical care, and we're still working with them actually to try and get a little girl who had a really nasty corrosive esophageal injury to Kenya for a dilatation, so that she can eat orally again. The local government hospital managed to kind of place a makeshift gastrostomy using a urinary catheter, and she's gaining weight, and she was stable when I left, but obviously she needs kind of something definitive. So yeah, lots of paperwork and referral letters, chasing up all your bloods and your X-rays from clinic and what have you. And then once a week there was a teaching session in the afternoons or a QI meeting, something like that. Once a month that would be an X-ray teaching. So here's this is a baby that I admitted who had sepsis and a new diagnosis of a VSD. The admission X-rays on the left. So he really improved with some IV antibiotics and some frusemide. You can see from the image on the right, he's slightly less overloaded. But he also had this diaphragmatic eventration as well. And it was something that we discussed quite a lot in our meetings and got some advice from some of the local kind of radiologists as well. And he sadly died because we just couldn't get him stable enough to get him somewhere that had cardiology and respiratory and intensive care facilities for essentially a tiny baby. I saw 2 dextrocardias with situs inversus in the year, which I thought was a bit funny. I don't know whether that's just a statistical anomaly, having not really seen very many of those before. And we saw plenty of this as well, osteomyelitis. This was by far the worst case I've ever seen. And obviously I did my elective in paediatric orthopedics as well. And this little boy, I remember that the family weren't able to commit to the long-term hospital stay because he would have been in hospital, for months with multiple surgeries, and they just didn't have the finances to be able to commit to that. So actually, he was self-discharged and taken home. So there was lots of kind of things like that you just don't come across here, do you? With all services being free at the point of care. So yeah, if you're on call, then you'd have to head over to the ward, get a handover. Often there'd be some bloods to chase, sick patients to be aware of, all of those, normal kind of things for a junior doctor. All of our clinical noting and lab results were electronic, which is absolutely amazing. So here's some of the blood results of a 4-year-old that I looked after with presumed Bartter syndrome. I spent a lot of time on the phone to Yincent about this little girl. She did absolutely amazingly well, and Mum was so grateful. So Mum had 10 children and 6 of them had died. They'd all got to about 3 or 4 years old. Started losing weight, got really lethargic, got really weak, and then passed away. But this little girl did brilliantly. The people that are paying attention might have spotted some. Well, I mean, the initial bloods aren't great, but the bloods that I thought were really interesting were these ones. So the calcium of 1.8, and when I went to see the girl, that's her hand. So she had actual tetany, which is something I'd never seen before. So when you're on call, you never know what's going to happen. This is Baz, one of the consultants, and he is in that photo making me some tubing connections that will link up to an underwater seal with some giving sets and syringes. And then he got some gaffer tape out the back of his 4x4 to tape it all together. And that's because there was a 10-month-old baby who had a tension pneumothorax and, as you can see, a pyothorax as well. And we didn't have any chest drains small enough, but we had some adult central lines that were left over. So one of the other very experienced consultants said, well, you can use that. So I put that in. And then, of course, we couldn't get it to hook up to the underwater seal. So that was a bit of a Jim will fix it kind of moment with Paz sellotaping things together. But this was another child who recovered fully after a lot of antibiotics and TB treatment. And his lung reinflated and it stayed up as well, which is just incredible. And I saw him 6 months later and he walked into my clinic room and I didn't recognise him because he'd put on so much weight and he was such a bonny little lad. So that was a really great outcome. So my initial reflections kind of 4 or 5 months into the job was, I had a real appreciation for going back to the basics and trying to understand basic physiology, because that was sometimes the only way you could then work out what was wrong with a child, if you didn't have all the diagnostics available that you'd normally have, and then working out what treatments that you could give as well. And it kind of made basic physiology interesting for the first time ever. I'm not a book person. I'm not very clever. Something has to be practical and I had to see the application for me. So that really helped. And definitely the learning curve was extreme, but I could see that I'd come a long way and I'd learned a lot. And a lot of people said, well, isn't the work overwhelming? Don't you feel like it's just a drop in the ocean and what have you? But I very much realised that the differences that you can make to individual lives each day, to that little girl in the clinic that you see, or that, that bigger boy on the ward or what have you, that's the thing that was giving me stamina to then, work towards understanding a little bit about some of the broader problems that you can face in a resource poor setting. But then COVID came and everything changed. Essentially the COVID surge came much later in Gambia than the UK, and it wasn't, thankfully, it wasn't as bad as some of the initial modelling predicted. Why this is exactly, not sure. It's certainly a bit of a hot research topic and there's lots of theories going around. But it did mean that we had some time to prepare. And the preparations were taken on by every single team within the unit. It was absolutely incredible. I kind of, brainstormed out for a few minutes and just thought of some of the teams that I came across. And I'm sure there's some that I will have forgotten. But clinical labs. So this is a photo of Abdul Cisse. He's just the most incredible man. He's the head of genomics. But there was a whole team of technicians and scientists working in the lab who had to start the testing. So the MRC was the first facility in the country to do the COVID tests. And then they just had to scale up rapidly. They had to train other people. They had to disseminate all of their knowledge and processes to the local Ministry of Health as well. They worked really hard under really difficult conditions. and they're kind of the unsung heroes because they were always hidden away in the labs. HR, you don't necessarily always think of kind of them as working really hard, but I mean, they had to redistribute staff, they had to work out which research teams, could come across to help clinically. They had to arrange for all the COVID payments for the nursing staff. They had to risk assess everyone as well, because obviously all of their team were either doctors or nurses working clinically, or they were working in the field, researchers. So which one of those people, could go out and continue doing home visits, who couldn't, all those kind of things. The communication department were phenomenal. They did a load of posters and videos for educating the general public. You can see some of these being put up here. But they also recorded all of our COVID training packages so that people could be trained without, all the trainers having to be present. And they did brilliant work in terms of communicating to the general public, but also to communicating to all of the staff at MRC, Twitter and Facebook and all of that. Health and safety, wow, the number of SOPs they wrote, but those were the really important SOPs that you turn to every day. The clinicians, I mean, the doctors and nurses obviously worked really hard, but the consultant teams, there was a leadership team of 3 consultants who kind of took on board coordinating everything, just worked their socks off. And they had this crazy whiteboard with all of these jobs written off. And as the weeks went on, it got neater and tidier and less jobs to do as they just ploughed through this huge amount of work to do. The estates team, they built 3 extra wards and a massive doffing shed as well. They completely changed the layout of OPD for us, that we could have a hot zone and a cold zone. And it was all done within a few weeks. Stores, the procurement and logistics during that time were a complete nightmare. The borders were closed, so even if you could find stock to buy and you thought it was good stock, to actually get it in country was really difficult. Pharmacy, I mean, stocked up on things like dexamethasone, but they also worked really hard on trying to secure extra morphine, for palliative patients, and low molecular weight heparin, things that weren't kind of our bread and butter medications to begin with. That's some of the doctors wearing all of their lovely PPE. The IT team, so all of the COVID escalation plans, the clinical plans, were embedded into the clinical noting, and they had to add all the new wards onto the system and everything. Security, so initially MRC was the only facility providing the testing and also the only facility actually caring for patients with COVID as well. So it meant some really, really difficult situations for our security team. The domestics, they had so much extra cleaning to do, new protocols as well. They all had to be trained in wearing PPE. The banter bars, that's the canteen there to provide extra meals because suddenly we had 3 extra wards with all these extra patients. Accommodation, so the accommodation team actually had to move a lot of people around and make space on the compound because there was quite a few number of staff members who, if they were positive or had to self-isolate, they couldn't do it at home just because of the way kind of houses and families were set up there. So they worked really hard. This is one of our transport guys in his car. He probably looks a bit hot because they had to do all of their transport without the air conditioning on during the time. Laundry, obviously. And then there was loads of externals that we worked with as well. So these are some of the cloth face masks that were made and were given to all of the nursing staff, the doctors, and to all of our patients in OPD every day. We used a local 3D printer to print some kit, had to liaise with the Red Cross in terms of, support in burials. And then obviously the Ministry of Health, the leadership team had to be liaising with the Ministry of Health on a daily basis. So the preparations were just absolutely phenomenal. And I think working in a smaller unit like the MRC, you really got to see that far more clearly than I think probably that I would have done if I was working in the NHS. So here's a day in the life of a COVID doctor in the Gambia. Prepare to sweat like never before. So it's hot. It's always hot. Essentially, they have a hot season and a hotter season. But it was very hot during COVID. So, you start the day, plan of attack. Who's sick? Who needs testing? Who needs retesting? Because actually, so when COVID hit, we went from no local transmission to being full within a couple of weeks. And at that point, the government had a policy that everyone with a positive test had to be admitted to a hospital facility, and they couldn't be discharged until they had 2 negative tests. So we were really overwhelmed, I think it's fair to say, in the first few weeks with a lot of well patients, but who had a lot of admin to do because you had to keep retesting them. So you had to see all the new patients every day, and then to work out, who can go home as well. So once you kind of made a plan, divide and conquer, so there'd be a consultant coordinator who'd take all the referrals, and they tended to have like 3 mobile phones on the go at any one time, and they had to check through everyone's test results as well. So the test results came handwritten on bits of paper that were scanned in and then emailed. So it was a really laborious process to check through the results and actually work out who can go home, who needs to be retested and when. For the well patients, what we did actually was telephone reviews. So one of the doctors would sit in the office and phone around all the well patients. And then the hot zone team then donned all the PPE, took everything in with them that they needed, and you went round and, you'd do all your swabs, you'd have to do some bloods, do some prescribing, review the sick doctor, the sick patients. So after that, you'd come out, regroup, you'd have to change your scrubs because you'd be literally just absolutely wringing wet, drink another litre of water. So the days were really, they were physically tiring, and it was just overwhelming in terms of the numbers of patients we had, but actually there was very few really sick patients. And then obviously if you weren't working on the ward, then you go to OPD. And as I kind of mentioned before, we'd split into a hot zone and a cold zone. So the hot zone doctor had to see anyone with fever, shortness of breath, cough. So it's a slightly less sweaty place to work. But it was a completely new way of working, and OPD had to double everything. So we had to have a hot zone and cold zone phlebotomist and a hot zone and cold zone entry to pharmacy. So it was just a completely new way of working, and having so many new things to try and get your head around all the time, I think, as we can all appreciate, it just gets a bit kind of tiring, to be fair. And then the cold zone doctor, they were less busy because at that point we'd limit kind of how many outpatients that we'd see. But quite often it was more difficult to manage the patients well. There was limited referral pathways. All the charities were closed. You couldn't get anyone out of the country. But equally, the local government hospitals had closed down all of their routine work, so they were only seeing emergency patients. So there was some patients that you just got a bit kind of stuck with. And then because of all the border closures and all of the difficulties, we then had even kind of more issues with running out of medications and tests. Our immunochemistry machine broke, and then we couldn't get the part across the border to fix it. So all the people with thyroid disease, you just couldn't measure, their thyroid function. So titrating their meds was impossible, actually. So during the evenings and the weekends during COVID time, a lot of our time was spent writing guidelines and SOPs and kind of doing things like that. I wrote a few guidelines. I obviously wrote the paediatric clinical care guideline. That wasn't very interesting. But I was also able to contribute to the palliative care guideline for COVID and the difficult communication guideline. So the palliative care guideline was very much having to justify why do we need a palliative care guideline in a pandemic. Palliative care is a relatively new concept in West Africa. It's just starting to get a bit of traction. So there was a lot of explaining what is and isn't palliative care as well, a lot of kind of misconceptions and different views on it. And then thinking through the practicalities, right? How are we going to do palliative care? What drugs do we have? What formulations of those drugs do we have? How many syringe drivers do we have? Things like that. What non-pharmacy strategies can we use? But then a lot of it was kind of teaching and training and just talking about palliative care and kind of modelling good practice, just to help some of the doctors and nurses on the ward to think about it. So how do you go about assessing a patient, and little things like it's okay to use morphine, it is safe, and it's not nice to leave someone really breathless when you've got something that you can do about it. So that was a really interesting guideline to kind of be involved with. And the other one was the difficult communication guideline. So this covered, some basic communication skills, but it also set out a plan for how we were going to communicate during the pandemic. because none of the patients were allowed to have their families or their escorts. There was no visiting. So for the patients who were really sick, really breathless, couldn't, phone home to say how they were doing, how are we going to communicate to that family? And equally, if the patient gets so unwell that we think actually that they're dying, how do we then communicate to the family to get them to come in for a visit? So the plan was we'd have this communication bulletin so that clinical staff could, when they assess the patients, they could kind of essentially tick one of 4 boxes to say, they're really sick, we're really worried, come in for a visit. They're not sick, they're going home, something like that. And then the family liaison team, which were a group of field workers who were kind of retrained, could then do all the telephone calls and all of the linking. And the idea was that it would take the burden away from the doctors and nurses. So it was really great to be involved in thinking through that as a concept. And then I was able to kind of have some input onto the job specification when we were recruiting the family liaison team. And then I sat on the panel to interview them as well. And I'd never been involved in that kind of a process before. So that was really, really great learning. The communication guideline also had some bits on burials and bereavement because Gambia is mostly a Muslim country. So there was lots of kind of things that we had to think about around that. And equally, just in terms of communicating in a different culture, I mean, I could probably do a whole hour's talk on that. But in the Gambia, it's completely inappropriate to tell a patient or a relative that they're really sick and you think they're dying. So the guideline also contains some examples of different phrases that you might be able to use that were appropriate. We spoke with some local doctors and nurses, and we spoke with some local religious leaders as well to develop these phrases. So an example of it would be, despite all our best treatments, your dad is getting more tired. He's in God's hands now. And the translation of that, what we'd say in England is, we've reached the ceiling of care, we've given our maximum treatment, but your dad's still deteriorating. We think he's actively dying. So, again, that was a really complicated but really interesting guideline to be part of. But thankfully, the number of cases in Gambia levelled off relatively quickly, and it wasn't as bad as we'd thought. And the death rate as well wasn't as bad as it could have been. Thank goodness. So in terms of thinking through my reflections and learning points for the whole year, I mean, these are just a few of the things that I came up with. And I think it's fair to say that I'm still reflecting and still kind of processing a lot of the learning that I made. But it was just, it was an incredible year. So if I were to summarise things, I spent a long time on this slide. OOPE is amazing. Gambia is amazing. COVID was less amazing in terms of fun, but the learning and the experience were really significant. And when COVID initially reared its head, I initially felt really unlucky and cross that it had come during my year of OOPE. But I really quickly realised that actually it was the other way around. And I was so grateful to be in the Gambia during that time to support my Gambian colleagues in whatever small way that we did. And by the end, it really felt like we were there for such a time as this. So to end on a slightly happier note, that was me on my birthday with some of my amazing colleagues, and they managed to get me a gluten-free birthday cake in the Gambia. I mean, kudos to them, that was amazing.
Thanks so much, Daisy. That was a fantastic talk. So just a few questions. I got one. What do you think UK paediatric units could learn from your experience in Gambia?
Ooh, that's a really interesting question. So I think that a lot of my learning came from being more aware of some of the things that were happening at leadership level. And I think as UK trainees, we're very, very protected from all of that. But then I think it means that the ST8s then have a huge jump up to be a consultant, and they maybe have very limited management or leadership experience. So kind of being more part of the organisation and being able to come to some of those senior meetings and kind of get a much better feel of the broader things that were going on, I think was really powerful for me. And I think that it will have a huge impact on how I am as a consultant as well. So, you know, being a medical trainee, it's not just about the clinical side of things.
Yeah, and so do you think people like yourself have had that experience? Do you think we could come back to our training boards in the UK in terms of the improvements we could make to paediatric or medical training in terms of getting that experience earlier on?
Yeah, I think that's really valuable. And I think you can kind of almost see the change starting to happen from elsewhere. I know Namita Kumal's got her leadership academy, and things like that are great, but it almost needs to be kind of integrated into everybody's training. And it's most important for the people who don't find management natural, if you see what I mean. So if you're interested in leadership and you go to the Leadership Academy, that's great. But all of us are going to have to be consultants, and we're all going to have to fulfill that management leadership role. And to be honest, the pandemic kind of put us on the spot. But there's always difficulties and things that you have to overcome, and you have to be able to learn and to really draw on a wide base of experiences in order to do that. So I think we really should be encouraged more into things like that.
Perfect, yeah. And another question, obviously you saw a lot of conditions either that you'd never seen before, going back to textbooks, or where you were limited by investigations or treatment. So did you feel you had enough support in those situations?
Yeah, so the MRC was great. So we had a consultant team, and they were working really hard to provide a group of kind of guidelines and things like that as well. So there was always senior support around to ask for help. There was plenty of kind of local guidelines. Very often the first port of call for me would be the nurses, because they'd seen it all before and they'd done it all before, and they were far too polite to tell you. But I mean, my husband always tells the story of he was on the ward round, I think about 3 or 4 weeks in, assessing a patient and thinking, oh, I'm just not sure. And he turned to Mamina, who was one of the most amazing nurses I've ever worked with, and said, do you think this could be TB meningitis? And he just went, yeah. So there's plenty of people with loads of experience. And I was really well supported by the consultants back here as well. So Steve was great for kind of hooking me up with various consultants. I used to chat with Yincent. There was a little girl I didn't have time to tell you about, but a little girl called Ida who had TB and HIV and bronchiectasis, and she was a really complex case to manage. But we spoke with Matt Thomas. He reviewed the CT scans with us. That was great. I got some physio advice from the UK as well. In the age of Zoom and WhatsApp and up to date, there's always someone to ask for help.
Yeah, really good. So I think that's enough time for questions. I'm sure if you're okay, that people could either talk to you or email directly.
There's a great question actually that came in just at the very end there from Claire Stevens. So I'm gonna squeeze one more in. Claire asks, at what stage of your training did you go to the Gambia, and did you feel your experience was at the right level to deal with the clinical work? And I would just add to that, if not, and you can speak freely, obviously, what could we have done from here to have facilitated that for you a little bit better, perhaps? You were already very experienced when you went, but perhaps if someone who was not quite so experienced goes next time.
Yeah, okay, yeah, great question. So I'd passed MRC PCH, and I think I'd been a reg part-time, I think for 18 months by the time I went. So in terms of, that was kind of my clinical experience. I think what helped me is that I'd had such a long time working in Cambodia as well. So the whole cultural shock and working in a different cultural setting was a bit more familiar to me already. So that actually really helped, but obviously that's not something that everyone can kind of have experience of. I think that to a certain extent, it depends on your personality type and how risk averse you are, and everyone will have some insight into that. I felt it was a good time to go. I felt that I was safe, but equally learning a lot as well. I think the only thing that would have been really handy to have practiced or have had some teaching on before I went was procedures. But I know that there's someone in the region, isn't there, that's looking into that anyway. Because obviously in the Gambia, all of a sudden I was doing chest drains and pleural taps and acidic drains and what have you. And it would have been just nice to have done that or had a bit of a refresher before I went. But actually, by the time you've done one, then it all comes back to you anyway. So.
Well, that's great. And I'm just conscious now that I've managed to put us slightly behind schedule. That was a fantastic talk, Daisy. Thank you very much indeed. And I look forward to hearing more of your reflections as they evolve over the next few months. But fantastic. Thank you very much.